All right, today we're putting on our detective hats. We're going to dive into a really fascinating clinical case file. We'll follow the trail of clues, starting right at the patient's bedside and digging all the way down to the molecular level. Our goal? To solve the puzzle of a very rare and very serious genetic disorder called Wolman disease.
So, here's our game plan. First, we'll meet the patient and see the initial clues. Then, we'll hit the lab to gather some hard evidence. After that, we're going under the microscope to see what's really going on biochemically. And finally, we'll look at how we can manage this condition. Ready? Let's get started.
Okay, so every single medical mystery begins with a person, with a patient. Let's step into that exam room and see what the first signs were, the clues that told the doctors something was seriously wrong here.
So our patient is a 2-month-old baby boy. And right away, that age is a huge clue. I mean, when you see serious symptoms in an infant this young, your brain as a clinician should immediately jump to congenital or genetic causes.
So his parents bring him in because he's been having persistent vomiting and chronic diarrhea. Now you might think, okay, lots of babies have that. But here's the kicker. He has a severe failure to thrive. He was actually born perfectly healthy, but now he's just not growing. That's the alarm bell right there. It tells the medical team this isn't some simple stomach bug. No, this is something deep, something systemic. All right, the physical exam gives us even more pieces to the puzzle. The poor little guy is cachectic, which is just a medical term for severe wasting of muscle and fat. And his belly, it's really distended, really swollen. The reason why is a classic clinical sign, something we call marked hepatosplenomegaly. I know, it's a mouthful, so let's break that down.
So, hepatosplenomegaly. Sounds complicated, but it's pretty straightforward. Hepato refers to the liver, spleno refers to the spleen, and megaly just means enlargement. So we're talking about an enlarged liver and an enlarged spleen happening at the same time. And let me tell you, when you find that in an infant who's this sick, it is a massive red flag. It screams that something is getting inside these organs, building up and making them swell.
And the clock is ticking here. The situation is getting more and more urgent. The doctors are doing everything they can, supportive care, hydration, trying to get nutrition in, but the baby just keeps getting worse. You see? This failure to respond to the usual treatments is another huge red flag. It forces you to think, okay, what are we missing? It's time to dig deeper, to look for some kind of underlying metabolic problem. Okay, so the clues from the bedside exam are pointing us in a certain direction, but suspicions aren't enough. We need data. So now it's time to head to the lab.
So, I want you to think like a clinician for a second. You've got this tiny patient who isn't growing, with a massively enlarged liver and spleen. What tests are you ordering? What's on your differential diagnosis list that you want to rule in or rule out? Just think about it.
Wow. Okay, the lab results are in, and they are dramatic. Just look at this lipid panel. The cholesterol and triglycerides are through the roof. That is absolutely not something you expect to see in a baby. And at the same time, his liver enzymes, the AST and ALT, are sky high. That confirms there's some serious liver damage going on. This whole pattern, it's pointing a giant, flashing arrow right at an inborn error of lipid metabolism.
But then we get the CT scan. And this, my friends, is the smoking gun. It shows bilateral adrenal calcification. Calcification of both adrenal glands. This isn't just another clue. This is an incredibly specific finding. When you see this in an infant who has all these other symptoms, it's what we call a pathognomonic sign. It's a classic hallmark that points to one very specific diagnosis, Wolman disease.
So everything is pointing in one direction now. But in medicine, you always want to be 100% sure. You need definitive proof. And the gold standard test to confirm this is what's called an enzyme assay. We're actually going to measure the activity of the enzyme we think is broken right inside the patient's own cells.
And there it is. The results come back, and they are absolutely conclusive. The activity of the enzyme Lysosomal Acid Lipase, we just call it LAL, it's pretty much zero. It's just not working. So we officially have our diagnosis. This is Wolman disease. Now we know what the problem is, but to really understand it, we have to go deeper.
All right, with the diagnosis locked in, we can change our focus. We're going to zoom in, way in, removing from the patient as a whole down to the level of a single cell. Because to really get a handle on this disease, we have to go under the microscope and see exactly which piece of biochemical machinery has failed.
So this LAL enzyme, what's its job anyway? Well, in a healthy person, you can think of it like a pair of tiny molecular scissors. It works inside a part of the cell called the lysosome, which is like the cell's recycling center. And LAL's job is to chop up fats, specifically things called cholesterol esters and triglycerides. But in Wolman disease, there's a mutation in the gene that makes LAL. The result? The enzyme is either completely missing or just doesn't work at all. The scissors are broken.
This diagram just lays it all out so clearly. Check out the normal pathway on the left. See? Fats go into the lysosome, and LAL breaks them down. Nice and clean. But now, look at the Wolman defect on the right. The fats go in, and they get stuck. They're trapped. With no working LAL enzyme to process them, they just accumulate and accumulate, turning the poor lysosome into this bulging, toxic storage locker for fat.
Okay, and this is where things get really wild. It's a total paradox. The rest of the cell, the main part called the cytosol, is now desperate for cholesterol because it's all locked away inside that dysfunctional lysosome. So what does the cell do? It thinks there's a cholesterol shortage. So its internal machinery panics and starts making more cholesterol. It's a vicious cycle. The cell floods the body with even more lipids, which of course just get trapped in the lysosome too, making the problem even worse.
So now that we've seen the chaos happening at the cellular level, let's zoom back out. We can finally connect all these biochemical dots back to the symptoms we saw in our patient, and, most importantly, talk about what we can do about it. And this is where it all comes full circle. It's that aha moment. That massive pileup of lipids isn't just a problem for the cell, it has devastating effects on the whole body. It's what makes the liver cells swell up and get inflamed. That's why we saw those high liver enzymes. The exact same process is happening in immune cells all through the gut, the spleen, and the adrenal glands. That's what's causing the diarrhea, the hepatosplenomegaly, and that classic adrenal calcification we saw in the CT scan. You see, it all connects back.
So, if the whole problem is a missing enzyme, what's the most logical solution? Well, you replace it, right? And that's exactly what modern medicine can do. It's an incredibly elegant solution, and the treatment is an enzyme replacement therapy called Sebelipase Alfa.
Honestly, this therapy is a total triumph of biochemical engineering. What Sebelipase Alfa is, it's a lab-made version of the human LAL enzyme. It's a perfect copy. So by infusing this working enzyme into the patient, you're basically giving the cells the one tool they're missing. You're giving them the molecular key they need to unlock those clogged up lysosomes and finally start processing all that trapped fat. I mean, this case is just a beautiful example of what we call bench-to-bedside medicine. Think about it. We went from figuring out that one single enzyme was broken, all the way to creating a targeted therapy that can actually save a patient's life. It really leaves you with a hopeful question, doesn't it? As this kind of technology gets better and better, what other rare genetic disorders, ones we used to think were a death sentence, might be next on the list to conquer?